This is the No Stroke Podcast with your co-hosts David Dancero and Michael Garrow, helping you to support and thrive in life after stroke. Their podcast is designed for educational and community support purposes only and should not replace medical treatment and guidance of your own health professional team.
Welcome to episode 43 of the No Stroke Podcast. My name's Dave Dancero. I'm here with my co-host Mike Garrow.
David, I know we're approaching fit. I'm excited for this 50 number that we're getting close to.
Yeah, that's a milestone. You're a bit hung up on how are we going to make this special? I mean, every episode with you, Mike, is special, but like we have to give it some thought, right? For the big 5-0.
Yeah, absolutely. You know better than I how important the big 5-0 is.
All right, enough. Let's move on. All right, be kind. All right, so we've been on a tour of Australia in the last week, haven't we?
We have, yeah. We've gone over. It was, celebrated National Australia Day recently. We've had two great guests that we were able to sit down with this week and record. And for this episode, we're going to release, kind of the first of a 3-part series that's going to, be speaking to some phenomenal folks, working both, closely tight knit to Australian stroke care pathway, and then we're going to have a guest that's actually from Australia, but working here in stateside as well, out of Mount Sinai in New York. So really excited for the next few episodes. But yeah, today's guest came from a connection who we'll be speaking to in our next episode, Kim Melkin of the Angels Initiative, which is really cool program that is doing phenomenal work to really be the connectors over there in Australia and global. So we'll speak to that in the next episode. But today we have two esteemed neurologists who are going to be joining us, both Professor Stephen Davis and Geoffrey Donnan from the Australian Stroke Alliance, who've over the last few years have raised nearly $40 million in grant money to really. What's fascinating is, we had Hyperfine on to talk to some of this brain imaging that is trying to go to the bedside. And if you followed the research, Australia has really led the way in these mobile stroke units and fascinating research and outcomes that they've been able to deliver, remote parts of the country over in Australia. And now, again, the brainchild of Stephen and Geoffrey here, they're saying, you know what? Ground ambulance isn't enough. Let's bring it to the air. So really cool conversation. But yeah, what were your thoughts on it?
No, it just, there was so, first of all, I didn't really understand the geography and the terrain and the obstacles in Australia. They put it in perspective in terms of size, about the size of the United States, but certainly the area, the concentration, metro versus rural, there's a lot of remote areas that, and we're going to get into, how they're solving that problem. But what really I was reflecting on, and I did when we went to break, I got a chance to kind of comment to them privately that, I was reflecting here in New England, in the Northeast here, how what I had access to for care during treatment for my stroke. And they mentioned in this interview, and you'll be, our listeners will be hearing how at one point or another, they both did early training at MGH, right in Boston. And, it was so interesting when you'll hear them talk about the early days of PET scanning and, they called it chasing the penumbra, right? It was the first time that they were, really could dive into that ischemic area and building systems of care. So I found that fascinating. I was also, when they go into talking about the distance later on and the barriers to, we talk about time is brain, but, I looked at I had access to 50 miles if I wanted to go to Boston, 12 miles if I wanted to stay in Rhode Island, but all had stroke centers in both instances. And when they talk about the distance to care, we're talking in some of those rural areas that there's 200 kilometers or over 100 some odd miles between the ability to get care. So when we get into this, it was really, it made me reflect on, how fortunate some of us are, and then the barriers that,
Totally.
that we get into, and the technology solutions that they're going to talk about are just fascinating. It's so, so interesting.
Yeah, totally. I mean, from the numbers, it's, 3% of patients in rural areas, in remote areas of Australia are actually getting access to stroke treatment, whereas 77% in metropolitan areas are getting to a stroke center, and as we'll talk to, it's, Australia is in a unique position where, they've been fortunate to really be leaders in stroke care for so long, where, they're now at a point where they could kind of be the test grounds for these other countries that, similar type of geographies are having the same issues, right? So really fascinating stuff. So just quickly, other things that I know we have kind of been happening that we just want to touch on before we get into this interview. Caroline Brown, great friend of ours, who's doing some fantastic work here in Connecticut with Stroke OT. You could go back to listen to her previous episode that we had, but she was highlighted in the news, kind of local news station here recently. Really, and what I found fascinating, the news anchor kind of led this up and said, the issue with stroke is that it's treated the same way, or you get the same level of rehab as if you went and got a knee replacement, right? So it's interesting. Like, I'm happy they kind of set it up in that sense, where then Caroline, and one of the survivors who has been in her program for a long time, kind of spoke to the needs of long-term therapy, right? And we may put a post up there on our LinkedIn page, really just showing like, look, until we have value-based care models come through and we're at a point where outcomes actually matter to a degree, it's going to be these organizations, these volunteer-based, groups that are going to be the only access point for folks who are underinsured and can't, pay out of pocket for the likes of a Mike Studer to be able to, provide care and have that access to long-term therapy. So I'm just really happy to see, Caroline get highlighted. And, if you are in the Connecticut or kind of Northeast region, please go to strokeot.org and kind of learn more about her program.
Yeah, Mike, and she's such a champion, and it was so great to see her highlighted for all the work she does, and bringing in the patient perspective there too as well on that highlight piece. So, and along the line, sort of in recapping the week that was, and you just mentioned Mike Studer. Mike put on an event. Mike was our guest on the last episode, and he put on an event to benefit the work that Oregon Stroke Organization does. And this was Friday, and it was really, I was able to jump in and attend that. It was really well done in terms of budgeting exercise. And I think his perspective, we heard him talk in depth about dual task training and a lot of the, the evidence around retraining the brain. So I hope he puts that up. I hope they, repurpose that to put it up, because it was really, again, highlights the hard work of, volunteers too, like Mike in that instance, that are stepping up to say, keep at this, right? The system may not be in place to continue your care, but there are resources available, and, he gives, again, hope as part of the plan is a big thing.
Mm-hmm. Yeah. And, just lastly, we do touch on it in our interview with Stephen and Jeff, but, this is our first episode after, the passing of Dr. Ralph Sacco as well. So condolences out to, his friends, family, colleagues. He was really a trailblazer, in the neurology space, and specifically, for advances in stroke care. So I know, I've been learning a lot about his work, especially with this Northern Manhattan study, me being in New York, just the diversity, obviously, the population here is fascinating to see, this research that started back in the early 1990s, still continuing to really assess, predictive factors for stroke, and then all the way through, what mortality rates look like, and, access to rehab as well. So just, sad, kind of moment in time here for the stroke community. And I know Stephen and Jeff knew, Ralph personally, and obviously Pam Duncan, a lot of our past guests, we're close friends and colleagues. So again, our condolences, and I'm sure, I'll be out at the ISC, the International Stroke Conference, here in the next couple of weeks, and I'm sure, again, there'll be memoriam to him and that work. But if you are heading out to the ISC here in Dallas, I believe first week of February, we'd love to have a conversation, speak to your work. So if you're heading out, I've already kind of talked to a few folks. I know Lester Young, he'll be there. David, you were really involved in some of his young adult stroke work, so excited to have a conversation with him, sit down again. But it's obviously a hard way to kind of now get into this interview, after having to speak, to that and passing of Ralph. But I think an important tidbit that came out of a conversation with Pam Duncan is, one of the last conversations she had with him is, look, Pam, somebody needs to keep continuing to push this forward. And there's, I know, between the survivors, caregivers, healthcare practitioners, whoever you are, some way, if you're listening to this, you're connected to stroke, and, it's not going to take one person, it's going to take a community. So, again, continue advocating, continue, asking the hard questions, and, we'll be doing our part to see what we can.
We all have to keep collaborating. And with that said, let's jump into this great international collaboration now, right? This is glad to continue to expand the reach and the voice to connect care and stroke. So without further ado, let's begin this interview.
Hi, welcome to the No Stroke Podcast. We are sitting here. It's our pleasure to have two esteemed neurologists here, our first Australian guests, both Professor Stephen Davis and Geoffrey Donnan. Welcome to the podcast here, gentlemen.
Thank you.
Thank you.
Absolutely. So, Jeff, let's start with you. And, just if you guys could both, kind of give a bit of background, on your esteemed careers in stroke care and as a neurologist, and what kind of got you guys together? Because it seems like you have a powerful duo right here.
Well, the interesting thing is that as I describe my career, it's almost the exact parallel of my friend and colleagues, Steve Davis, who amplified. But we actually went through medicine together at Melbourne University. Although I think we could say, Steve, we didn't know each other particularly well then, but we were then what we call in Australia residents and junior doctors together. And then we started training in neurology together, and we diverted a little bit in that I went off to the US and Stephen went to the UK. He'll tell you about that. I had 2 years at the Mayo Clinic and then a year at the Mass General. There was a terrific time in my life, wonderful to get insight into how the rest of the world looked at neurology and stroke in particular. And I worked with tremendous people such as the great Jack Wisnant at the Mayo Clinic, who was a magnificent epidemiologist, and at Mass General, the early days of PET scanning with Bob Ackerman, and then came back to Australia, where I was director of neurology at the Austin Hospital for many years, then at the Florey Institute, and then back together with Steve at the Royal Melbourne Hospital. But we've been collaborating on stroke projects together probably from the time we both got back from overseas in the early to mid 80s. And it's been, as you say, Michael, a very productive relationship.
Well, so both world travelers. So, Stephen, let's hear about your time in the UK.
Yeah, so I trained in neurology in Melbourne at the Royal Melbourne, and then I wasn't sure what I wanted to specialise in, but I remember my mentor at the Royal Melbourne saying cerebrovascular disease, and I went to London. I had a kind of fellowship position at the National Hospital Queen Square, which is like a finishing school in neurology. But they don't have an emergency department, and they don't treat stroke patients. So I thought staying there was not a good idea, and I was fortunate to obtain a fellowship at the Massachusetts General Hospital, which Geoff mentioned, and worked with Robert Ackerman, and Geoff was there shortly after me, and early PET scanning and stroke. And it was a very, very exciting time in stroke because basically there was no acute therapy. There was very little preventative therapy, so it was pretty much a blank sheet. And I think we were incredibly lucky to be at that early stage where we could really see the future prospects. And I just mentioned with the PET imaging, these showed for the first time a theme of our research for many years, the so-called ischaemic penumbra, which is the magic area in the brain which is at risk but salvageable, and it could be visualized for the first time with PET imaging. And Geoff and I have spent much of our careers chasing the penumbra, getting the blood flow back in, saving brain, I guess, has been the theme of much of our career together.
Yeah, so a unique blend of, worldly experience, kind of seeing how systems operate, in different parts of the world, and interest obviously with neurology. A large part has been, this neural imaging, right? But I think that's something you guys have really taken and run with. So we'll certainly dive into some of the amazing work that you guys are pursuing. But, as you're our first guests here from Australia, we have a lot of listeners here in the States, UK, central parts of Europe, but, stroke, when you have a stroke, it's the same no matter where you are. You could have a stroke here, you could have a stroke on Mars, it's still a stroke, right? But the care and that coordination, that's where systems across the world, different geographies, are different, right? So can you just set the scene, from an Australian perspective, what are some of the challenges that you see within the system today, and what are you kind of working through? So maybe I'll pass this one maybe to Geoff, if you want to take
it. Thanks, Michael. Yes, you're quite right. Wherever you are, at the end of the day, a stroke is a stroke. But you've touched upon the important issue. It's all about systems of care, and systems of care are very dependent upon geography, and no more challenging geography than is present in Australia. As you know, the size of Australia is only a little less than that of the US, so it's a massive country, and about a third live in rural and remote Australia, and much unlike the US and Europe, much of Australia is very remote. Desert, in fact, but throughout these remote areas are scattered villages, if I could put it that way, where access to stroke care is very, very limited. So not only that, within Australia, like many countries, we have an Indigenous population. And this Indigenous population, parallel to the experience in other countries, is only, well, it's only 2 or 3% of the population. They are very poorly cared for. Their access to care is very, very poor, mainly because of remote locations, but there are many other factors we can talk about as well. But that sort of sets the scene that Steve might expand upon. But the geography that we experience, we think other similar ones might be, you might think of Canada, you might think of China, you might think perhaps of Russia, the expanses across Siberia, and even Africa. The same sort of geographies exist, where the same challenges of remote communities which need to be served in the same sort of way as metropolitan communities.
Yeah, perhaps just comment. Stroke's undergone a revolution in treatment in the past 20 plus years, and particularly in the last few years with thrombectomy, pulling the clots out of the blood vessels, which has been, the term game changer is perhaps a little overused in medicine, but it really has been an extraordinary game changer, because for the first time you can see where patients are treated quickly after the onset of the stroke with clot dissolving treatment, thrombolysis, and then with thrombectomy, the reduction in disability is absolutely striking. We've got the randomized controlled trials to prove the benefits, but we see the benefits of people walking out of hospital very early on after the treatment of often quite severe strokes. So the problem is, in metropolitan settings, people are accessing these new therapies. But as Geoff mentioned, in rural and remote Australia, that's a third of Australia. The outcomes are much worse because people can't access treatments in a timely manner. So that's been the basis of our current research of trying to move the hospital to the patient, develop lightweight brain imaging to put into standard road ambulances based on our mobile stroke unit experience, and put them indeed for the first time in aircraft. So we can treat people remotely, use digital technology to link the coalface providers with experts who might be quite remote.
Thank you for describing that, the scope of the problem with the distance and time, as we know, with time being brain for stroke and stroke treatment. And I didn't realize that a third of your population is in rural areas. So you just started to describe part of the solution there. Can we dive deeper into the more around those objectives that you set to meet with your effort here to change the way stroke care intervention is delivered?
So it's all based, perhaps I'll kick off and then Geoff can continue. It's all based on time. In Melbourne, we set up the Melbourne Mobile Stroke Unit, which is an ambulance with a CT scanner and a mobile stroke team that goes to the patient. And that saves about an hour in metropolitan Melbourne, and it delivers better clinical outcomes. We've just analysed, in fact, some of our further results in the so-called golden hour, which is 60 minutes after stroke onset. If you use thrombolysis, about 2/3 of patients make an excellent neurological recovery, which is much greater than at later time periods. So earlier is better, and that's fine, but there's one unit in Australia. There will be more metropolitan, probably standard mobile stroke units, cars, ambulances with scanners in them and teams, and often using, I think, telemedicine in the future. But the problem is the rural and remote areas. The scanners are expensive, they're heavy. The current standard fairly lightweight scanner, much lighter than the hospital scanners that we use, is half a ton, 500 kilograms. And we are working with companies to develop solutions to be well under 100 kilograms, the weight of a person or less, and that will be cheap, that will be highly portable, but deliver diagnostic qualities so that we can, for example, distinguish between ischemic stroke and hemorrhage, use thrombolysis, ideally be able to pick large vessel occlusion, so treat the patient in the field and take them to where they can be best managed. Jeff?
Yes, just to expand on what Steve's saying, as he emphasised, it's all about time. I suppose I'd say there are two key issues. One is time, and the other is image. Image and time together, and the way we've got things arranged, if you disregard the mobile stroke units, which are few and far between around the world, it's basically, under normal circumstances, 3-ton imaging devices in hospitals. So the time lost is in fact patient to hospital instead of image to patient. So we're reversing that management trend, if you put it that way, to take the image to the patient. And to do that, the obvious thing is you can't take a 3-ton image to the patient. So as Steve said, we're working with 2 companies, particularly startup companies here in Australia, to develop these, I think, amazing lightweight imaging devices, which are still very preliminary, I must emphasise, but show a lot of promise. So just to talk about those for a second, the first one is the MicroX company in Adelaide, and it's using a quite a novel nanotube technology with cone beam CT, which is now in the preliminary stages of development. We've seen some of the early images, which look very, very promising, although I emphasise still a long way to go. But if that can come to fruition over the next 3 or 4 years, that will be, as Steve said, under 100 kilograms in weight and would act just like an ordinary CT, or very near to. And the second company is EM Vision in Brisbane. It's a northern, more tropical city in Australia, I think Florida, that is developing an electromagnetic imaging technique. Again, perhaps a little bit further down the track, they've got prototypes that exist, and we've looked at the images, and they look also very, very promising, but that needs to be validated, and that'll take another year or 2 at least. So both, and that imaging device may even be as light as under 50 kilograms. So that's quite staggering, and we'll be able to put them in not only road ambulances but air ambulances.
That's fascinating stuff. Again, and I think time, right, and we always have talked, time is brain, but yeah, that imaging quality, especially with what you guys are looking to do by bringing this to the patient, is quite important. We spoke with a company here that's in the US, I think they have some global presence as well, Hyperfine, and they're trying to bring a CT scan, to the bedside, within hospital systems. And one thing that, it's that image quality, right? Because as you take that, 500 ton, or the 5-ton machine, and you scale that down to fit at a bedside or fit into an ambulance or an aircraft, like that's really, and I'd be curious, like with the testing, the validation of this test or technology for the imaging, are you putting it in like aircraft simulations to see? Because I mean, that's the thing, right? Roads are bumpy and the air has turbulence, so that impacts it. Yeah.
Well,
yes,
the first.
It's going, Steve.
Yeah, the first challenge is you're quite right. I mean, for aircraft deployment, things like ruggedization, as they call it, is very, very important, and temperature and charging, etc. But the big challenge that we're focused on is when you see someone with the features of an acute stroke, is to distinguish ischemic stroke from hemorrhage, because they can clinically present in a very similar manner. and you can't be confident to use something like thrombolysis without certainty that you're not thrombolizing a cerebral hemorrhage. And then secondarily, there are stroke mimics, so subdural hematoma, for example, brain tumours that we also want to be able to diagnose. So that's the first thing is really testing these devices in hospitals to determine their sensitivity and specificity for distinction of fairly small brain hemorrhages and stroke mimics. And then, of course, you're absolutely right. We're doing parallel kind of stream research where we are looking at installation in standard road ambulances and working, for example, with aerospace engineers to look at putting them in aircraft. So that work goes on in parallel. But the first thing is to ensure that the devices are accurate enough for us to confidently treat.
Yes, as we know, academics love collaborating, and we talked about Steve's and my collaboration over the years, and I must say we both agree this is the most exciting collaboration we've ever done because it's a little bit different, as you can think. Most of our research has been around the ischemic penumbra, clinical studies, mainly collaborating with fellow clinicians, radiologists, et cetera. But this one is right out of the box, I must say, and to be collaborating with engineers, computer scientists, AI scientists, aerospace engineers, as Steve mentioned, materials engineers, Kate Fox. So this brings an array of expertise to a collaboration we've never experienced before. So out of this, we think something special can happen, but it does emphasise that to make these breakthroughs, I always hesitate to use that word, but to make these advances, you do need to have a very open mind about with whom you work. And we're putting out feelers everywhere. And you mentioned the Hyperfine company, Michael, I think, was that we've certainly had discussions with them, and small MR is another very important way to go. And we're working with another New Zealand company with the same sort of aim as Hyperfine. But the Hyperfine, it's a bit more challenging to get MR into the air than CT. But the MR to the bedside, which Hyperfine's doing, I think is a tremendous advance.
Great. So, yeah, I know you touched on some of those partnerships and the, aerospace engineers. I mean, I guess I hope we're not, I mean, we might be the most, boring call for you this week. I mean, if you're talking with people from aerospace, but, what's unique about what you're doing, you are saying, we've mentioned terms like breakthrough, game changing, but I think what I'm most curious about is like, this is nuanced stuff, right? Like there are no other, when you think of like the population, we spoke to Australia being very remote, and you mentioned some of these countries that are similar. Are you working with other countries that, again, experience, obviously it would be ideal if this was in every place, but like some of those countries you mentioned, obviously they have the same issues, right? This hasn't really been done before. Are you collaborating with people outside of Australia as well?
I think that there's sort of two levels of the collaboration. The answer is yes. The first thing is that there's a worldwide collaboration focused on pre-hospital care in mobile stroke units called PRESTO. Good name for time and speed. The Pre-Hospital Stroke Treatment Organisation. So there are about sort of 35 or so mobile stroke units around the world, mainly in North America, some in Europe, and a few others scattered around the world. We're the only one in Australia, and there are only 2 or 3 in Asia. There's one in Bangkok and one in China and also one in India. So there's a lot of collaboration in that space. As far as the collaboration to deliver lightweight brain imaging with novel transport solutions, which is our theme, we've certainly in collaboration with colleagues in Norway who are very interested in air delivery. And we're keen to collaborate with colleagues in places like Canada, as Geoff mentioned. That will depend initially on testing these devices, and that's our immediate goal. And so that requires testing on site in Australia in the first instance with these companies.
Yes,
Brennan.
I think with the validation stage, I think that's where the collaboration, the global collaboration will intensify, because like all clinical trials, to be able to show that it works and is appropriate not only in the country, your own country, but other countries around the world, leads to greater uptake, because otherwise, as we've seen many times with various other interventions, if it's not shown, not to grasp it. So that will certainly be on our agenda.
I'd love to know what you're doing for follow-up care, and are you integrating, I saw on your website, you're integrating telehealth into your platform as well?
Yeah, so the critical thing with pre-hospital treatment is you can't have an expert at every case in, for example, Outback Australia. Currently, we've got the largest flying doctor service in the world. The Royal Flying Doctor Service is the biggest aero medical retrieval service in the world. It's just worth mentioning that, because that's been in existence for many decades. And Geoff and I and our colleagues have been to their headquarters in Adelaide, and you look at the aircraft being deployed all over the country. It's like another major airline. But so when they fly out to an outback sheep station or somewhere in Australia, they carry two people, including the pilot. Might be the pilot and a doctor or a specialised nurse, perhaps a paramedic. So absolutely integral to this research is working out digital solutions to link the coalface people with experts who can help to interpret the imaging and interpret the clinical features, and to say, yes, that's an ischemic stroke. We should use thrombolysis. It looks like there may be a large vessel occlusion. This is where you should be taking them. So that's the plan. So perhaps, Geoff, if you talk about how we're going with the digital approaches and our collaborations there.
Yes, thanks, Steve. We were keen to get onto this because it is there's no point in having these mobile devices on road and air without them being digitally connected. And we're very fortunate, and we've got our collaborators who have developed the name they've used is Zeus, which is a digital connectivity via satellite eventually, particularly using Elon Musk's Starlink, which would enable us to cover every corner of Australia, because the current mechanisms we have with various towers spread across the country means there are a lot of dead areas. So to be able to link this by satellite, and while only about half of Australia or a bit more is covered by Starlink at the moment, we understand within about 12 months or so it's going to be 100% coverage. As you know, these small, low amplitude, low height satellites there are literally thousands of them now in the sky, and Starlink is probably the cheapest and most reliable.
I think that was the first name drop to someone using Elon Musk's Starlink on the podcast. So kudos to you on that one, guys. And just to dive deeper on the telehealth capabilities and kind of how what was fascinating with me is that as I was kind of doing some research, really how you're thinking through this full circle, right? So as you mentioned, you're focused on the acute phase. You've had these outcomes from what we've seen by getting thrombolysis sooner in the process, but you're also, and maybe you could describe in detail, like, how are you taking that early onset data to then kind of go all the way to the patient side, where after discharge you're supporting them with follow-up care? Because in my mind, it's like, all right, you're then able to associate that full care pathway and have all that data right together, improve outcomes. So yeah, if either you, I'll let you decide who wants to chat through that. But
well, stroke's a continuum of care. You're absolutely right. We focus on everything from prevention to acute treatment, to having them in the right stroke unit, which we know improves outcomes, and then rehabilitation, brain recovery, community reintegration. So you're absolutely right. Working out clinical pathways is very important. And I'll give you one example of the challenge there. With our Aboriginal and Torres Strait Islanders, First Nations Australians, that's 3% of Australia. They are very averse to be taken off country. So it's been made very apparent to us that we need to work out solutions where they are reintegrated back to their own country as soon as possible. So you do have to individualise approaches to some extent. So they naturally have to be treated in a sort of an excellent state-of-the-art facility first, but then the nature of the rehabilitation community integration may be different for different settings. Geoff, do you want to?
Yes, you're quite right. The continuum of care is terribly important. It's safe to say that this current program is more front-loaded, and the emphasis has to be on that to solve this massive problem first. But at the same time, we're all involved with developing better follow-up paradigms around the country. For example, we're slowly expanding a national stroke registry program called OSCAR, which has now got nearly 150, getting on towards 200,000 registrants in more than getting toward 100 hospitals around the country. Eventually, we want it to involve every hospital. And as part of that, there's also a random follow-up to, you can't follow everyone up, but at least we get a pretty good handle on what the outcomes are going to be like. And for example, within that framework, particularly Dominique Cadillac, the professor of epidemiology who leads this program, has been able to show that during that follow-up period, and it's usually a routine 3-month follow-up, those that adhere to secondary prevention strategies, the stroke pack we call it, we like to make sure everyone's got as they leave the hospital, as antiplatelet agents, blood pressure lowering agents, cholesterol lowering agents, etc. Those that adhere closely to that, their outcomes are so much better. So we're on the job, but it's an even bigger job to go right through that continuum of care out to the other end.
Perhaps, as Geoff mentioned, we're mainly at the front end, and there's one other development which I think listeners might find quite exciting, and that's the prospect of telerobotic thrombectomy, which we should touch on. So, as you know, thrombectomy, pulling blood clots out of brain arteries, or endovascular clot retrieval, is a massive shift in acute stroke treatment. And if one considers the problem again here of remote communities, they don't have experts to perform this procedure. You need a highly trained, what we call a neurointerventionist, to perform these thrombectomies. So Geoff and I are conducting a program with collaborators such as Dr. Hal Rice on the Gold Coast in Australia, and Peter Mitchell in Melbourne, and others, to use a technique that's in its absolute infancy in stroke, but has been used successfully for aneurysm coiling and is used for percutaneous stenting in coronary artery disease. So the concept here is that you have perhaps a general radiologist to be able to insert the catheter in the femoral artery in the groin, and then using digital technologies. Geoff mentioned Starlink. We'll give Elon Musk another plug there. but you're connected remotely to an expert who might be in Melbourne, might be in the Gold Coast, might be in Boston, and they control in the whole procedure and perform the clot removal. Now, it's only been done in stroke in a handful of cases in the world, including under Hal Rice, a few cases in Queensland. But we're conducting some research at an early stage currently with in vitro experiments using models to test the potential of this technology, which I think is incredibly exciting. Robotics.
Yes, you can imagine that is, again, getting back to the geography of Australia, absolutely ideal for the geography that we're faced with. You may or might know the town that's right in the centre of Australia is called Alice Springs, perversely a spring, but if they don't have the ability to do thrombectomy. So if we're able to do that from Melbourne or Sydney or Brisbane for them in Alice Springs or other remote areas, it's an absolute breakthrough. So this is another very important area of our research.
This is why we're so excited about this program. We, as Geoff said, it's the most exciting thing we've ever done, and you know, we're at a stage of our careers where a lot of our colleagues sort of hang up the stethoscope and play golf, but this is too much fun to leave.
Well, I think, you know, with the, you know, not to, you know, kind of bring a damper to the conversation, but the passing of, you know, another, you know, really esteemed neurologist here in the States, Dr. Sacco, you know, we've worked closely with Pam Duncan here over the last few months. So we had her on as a guest, you know, and, you know, I think the work that he was doing, especially like the North Manhattan project, you know, is some of the early stroke work, is fascinating stuff. And, you know, she had an interesting perspective, and, you know, one of her last words to Ralph was, you know, somebody's got to keep pushing this, right? And it's folks like yourselves who are continuing to fight and you know, make a difference here. So, you know, thank you for everything you're doing here, not only for folks in Australia, but really bringing this innovation across the world, and plugging Elon Musk, because we're looking for a sponsorship. So if Starlink,
we thought he needed. We thought that Elon, who we haven't had the pleasure of meeting, needed some publicity. Geoff and I both knew Ralph Sacco very well, and he's a giant loss to stroke and to neurology, which has been recognised around the world. We're also fortunate, I mean, we've got a lot of younger, very talented younger people working with us, and the success of any innovative program is not just the outputs of the program, but training the next generation, and we're, I think, very lucky. Ralph actually was a great example of someone who was a superb mentor and teacher.
Yes, Ralph was a very close colleague of ours over many years, and he was a superb internationalist, not just focused on stroke within his own country. And I think that's the mark of a truly great contributor to academia overall. And as Steve said, he was a great proponent of leaving a legacy so that you're training other people. And we've got half a dozen younger neurologists who are coming through, strokeologists who are going to take up the mantle. So we'll certainly leave this in very good shape.
Well, so you know, let's, you know, certainly, you know, a couple more things we want to, you know, jump into with you guys, but before we do that, we're just going to take a short break here, and we'll be back to kind of wrap up the end and you know, really where you're trying to drive this to from an outcome point of view. All right, welcome back. We are here with Stephen and Geoff to finish up the conversation about some of this great work happening over in Australia. And, you know, we're fortunate to connect here through Kim Melkin, who leads the Angels Initiative out in Australia, which is a team kind of solely focused on care delivery and stroke care across the world, you know, more in developing countries. But I know we'll have a conversation with her in our next episode. But just to kind of tee up that conversation, would you guys like to cover some of that work that you've collaborated on?
I think we've both been involved to some degree in Angels, which is an amazing worldwide initiative. It was actually started by Thomas Fischer from Boehringer Ingelheim in Germany, who's just incredible. And they support stroke units around the world, particularly in developing regions, but also in advanced countries, and promote the use of acute treatments, particularly thrombolysis. And Kim is leading the charge in Australia, Kim Malkin. And we're working with them. Jeff mentioned Alice Springs. That's a great example of a centre that's just set up an acute stroke unit and starting to give, or have been giving thrombolysis to increasing numbers of patients. They drain an area, just for your interest, that's greater than the size of France and Germany combined. That's the geographic challenge.
They drained an area the size of France and Germany. Wow. Yeah, that puts things into perspective, huh?
And they have literally 80 or so small villages that they, small healthcare centres that drain to the centre in Alice Springs. And I think, Steve, the population of Alice Springs probably only about 2,000 or 3,000, but acts, as you can imagine, a hub with fully developed hospital. But they, as we were mentioning before, even they do a lot of radiology, they're not able to do thrombectomy.
Yeah, it's super important work, Angels initiatives doing. I know Thomas is going to be a big loss. He just is going into retirement as well, if I'm not mistaken. So maybe you guys can talk him out of it. I don't know. We'll see.
Well, he was honoured by the World Stroke Organisation for the work that he's been doing. As Steve said, that both Steve and I have been presidents of the World Stroke Organisation. It was, I think, during both our tenures that he started off this initiative as his role in Boehringer Ingelheim. He's been an absolute pioneer. It just shows one of the great collaborations between the private and public sector.
Yep. Yeah, it's amazing work. And as a family kind of run pharma company that's just had this initiative for so many years, it's world class for stroke care. It's very, very nice that we have that. So cool. I think we've covered a lot here today. As we look to wrap up each conversation, we have our famous magic wand question, but I think I'm going to hand it to David today to pass over to the two of you guys.
Sure. This has been a fascinating discussion. I've learned a lot, and I think that you've covered a lot already, but we always end our discussions with our guests around handing them the magic wand. And if we were able to give you that magic wand, how would you optimize and how would you feel that what needs to be changed about optimizing the stroke care pathway?
Well, I think we probably
answered a lot.
Almost the same thing, because if I had a magic wand, firstly, there would be no strokes because we would have prevented it. There's no doubt about that. We don't necessarily want to be managing people with stroke. So prevention is always the most important, but accepting that they occur, a magic wand would involve the instant implementation of everything we've been talking about. So that not only from the pointy end that we're talking about, but right through the continuum of care, where there was just total digital connectivity about the management across swathes of geography around the world, that would enable people to, when you think of it, to get access to care. When you think of it, almost every stroke is reversible if you get them early enough. So the magic wand would be every stroke treated within a few minutes of it occurring, and they would get up and walk home.
Yeah.
Yeah, I completely agree with that. And my magic wand, even beyond Australia, is 80% of stroke occurs in the developing world, low and middle income countries, particularly low income countries. I think the magic wand is, as Jeff said, to deliver. We have many of the answers. We don't have all the answers, of course, but we have a lot of answers now for improving outcomes after acute stroke. Massive changes. But we're not delivering them except for really fairly select populations in metropolitan centres. So the magic wand is to work out ways of delivering acute treatment to everyone. As one of our colleagues said, regardless of your postcode, regardless of your geography, regardless of your economic status.
You make a lot of sense, and as we start to speak with folks outside of the bubble here of the US, right, there's so many issues that stretch into the developing worlds that hopefully the research that you're putting in right now, and the technologies and the outcomes that you're able to assess will lead to some of the development that could support the developing countries and getting some of this off the ground and support it. So yeah, listen, it's been a fascinating discussion here today with you guys. We'd love to reconnect as the project continues. I'm sure there's going to be some great learnings that we'd love for you to share. So keep up the great work, and again, thank you guys for coming on here.
Thank you both.
Thank you, Michael and David. It's been
a pleasure.
A pleasure.